share that with you. But today, I do want to take this opportunity to, first of all, thank Dr. Adam Brodsky for taking of his time today. He's got some fans here, his patients, I love that. Dr. Brodsky is a doctor at the Heart and Vascular Center of Arizona, and because I won't do this proper justice, I think the greatest compliment is he's a friend of many people in the community, including my brother, as well as a member of the community, somebody who cares, and that's why he's here today. So thank you very much. I'm going to let him share more about himself so we can get to learn about how he ended up in Arizona. But again, thank you, Dr. Brodsky. We're all looking forward to this. I'm going to swap the PowerPoint.
Yeah. I think I'm standing back far enough that I can, yeah, okay, so I can take my mask off here. Okay, yeah, so my name is Adam Brodsky. I'm a cardiologist. I've been here in the Valley since 2005. I work downtown. I'm an interventional cardiologist, which means I do procedures. I put stents in people's arteries, things like that. This is going to be really laid back. I put together some slides on heart health, keeping your heart health for seniors, and we can, you know, like the rabbi said, if you want to get more food or something, that's fine, and then we'll have time for questions after. I'll try and keep it short. If you can't hear me, speak up or raise your hand or something, and I'll talk louder or more into the mic. So yeah, okay, so what I wanted to do is really just go over, I'm going to treat you sort of like my medical students or residents. We're going to go over one of the new guidelines that we have, and this is kind of how we collate all the vast amount of data that there is to help doctors learn what's the right thing to do in certain situations. So this is the guideline on what we call primary prevention of coronary disease. And we distinguish in medicine between primary prevention, which means trying to prevent people from actually getting the disease, versus secondary prevention, which is once you have the disease, how do you stay healthy and prevent yourself from getting worse? So the reason I make that distinction is because primary prevention is a lot harder. You might think that's not the case. When you're dealing with a primary prevention population, you're dealing with healthy people, right? So they're, you know, easy and regular like all of us. But the problem is, in my practice, if someone's already had a heart attack and they come and see me, so it's very easy for me to tell them what to do. They always listen because they're scared, and they'll do what I tell them. But it's much harder to take someone who's never had anything wrong with them and then say, you need to do this, you need to do this, stop doing that, because like they're healthy. What do they, you know, what do they need to worry about? So, but that's exactly where you want to put most of your effort, because you don't want to wait till you get a heart attack before you try to make healthy changes in your life. So we're going to go through just some of the points on this. Let's see, I can go down. I don't know, do I have to point to somewhere? Oh, there we go, okay. Yeah, so the guideline starts and it has like this top 10 list. So I'm not going to go through all of them, but just a couple of them that I thought, that's better, make sense. One is adults who are 40 to 75. Now the reason it tops out at 75 is simply because the data was derived using studies of people in that age group, and the number of people in the study that were older than 75, there weren't that many. We usually extrapolate this to the more older population as well, so you don't necessarily have to worry about that. But the point of this is that you should take a minute to get an individualized risk profile to see what is it for you, what is your personal risk of having a heart issue. And there's a way to do that. I mean, we learn how to do this in medical school, but there's an online calculator that we should go through briefly, if this works. So if you can click on the bottom link, and you can go to this, it's just a public website, they even make an app where they do this, where you type in a few things and it gives you a personalized risk assessment and then makes recommendations for what to do. And the big thing that this comes down to, I mean, it doesn't work, it's not the end of the world, we'll go through some, okay. So if you can, yeah, if you can scroll down, we can type in, we can like make a, it's okay. If it's going to take too long, it's not a big deal. I can show you the link later. But basically what it does is it takes into account your race, your gender, your age, your cholesterol, your blood pressure, other background features that we'll go through, risk factors, smoking history, diabetes, things like that. And you plug it in and you get a risk over 10 years of what is the risk for you of having what we call like a hard cardiac event, which means having to have a stent put in, having a heart attack, being hospitalized for a heart-related issue, something like that. And then based on what your risk is, you decide, okay, am I someone that I need to initiate treatment for? Or can I just, kind of live my life and not worry about it because my risk is so low? I wouldn't worry about it too much. But there's but that's a calculator that you can do. Well, the dietary changes, so the changes we have, and we'll go through some of these, come in different kind of categories. So there's like physical activity, exercise, there's dietary changes. Those are what we call, they're easy to do, they're low risk, they don't really have side effects, kind of, you should do that anyway. The big thing where this comes into effect is, or may change what you do is, and for most people that see me, is, do I need to take a cholesterol pill? Because that's the thing that for a healthy person that they would really need to do or not. Okay, so yeah, so right, so put some stuff in there and we'll see what we get, sure. So total cholesterol, you can put like 210 or something, that'll be like a little bit elevated, but not horrible. HDL, put 35, that'll be a little bit low. And that's the good cholesterol, you want that to be high. Blood pressure, so you can put 135, which is normal, but on the higher end. And then you can put no. And smoker, put no, because we'll do something like most of us aren't. Sure, yes. Okay, recommendation. And then it takes you to this whole page where it gives you, so on the top, your 10-year risk is like almost 40% that you're going to have an event. So that's high. Like right off, you're high risk. So we and those things we typed in, you can go back and do this in your own, but they weren't like horrible. I mean, it wasn't like you were a smoker, diabetic, blah, blah, blah. You were, the guy had a little bit high cholesterol, a little bit blood pressure that was a little high, not terrible. But so the risk for any 1 year is not that high, but it adds up. And so if you scroll down, it tells you in each thing, we're not going to go through all this, but what you should do. The bottom line, though, I'm pretty sure is that it's going to recommend that you start, drug therapy for risk. It's going to recommend that you take a cholesterol pill, given the cholesterol numbers that you have there, to lower your risk. Right. We'll go through this. And it's also maybe recommending getting a calcium score. We'll talk about that as well. Anyway, okay, so let's move on so you're going to go back to the slide deck. It's okay, yeah. So the first point is just simply get a handle on what your risk is, because most people are going to be surprised. Because again, you feel fine, you're healthy, there's never been anything wrong with you. But when you look over a 10-year time horizon, and most of us want to live another 10 years, right? So you see things that the odds are, a little different than you might have thought. And that's how chance works, right? You get away with it for a year, you get away with it for another year, but then in year 7, something happens. So, and we want to prevent that. Okay, so this is table 3, right? So this goes through all the risk factors, really. These are the things we have to worry about. So to go through them quickly, a family history of heart disease. So if you have, and what that means is a first-degree relative, mother, father, brother, sister, children who have had a coronary event, which is basically a heart attack or a stent, at a young age. If they had it in their 80s, it doesn't count. If they had it at a young age, less than 55 for a male, 65 for a female. High cholesterol. If you have high cholesterol, that's bad. A lot of these are obvious. Metabolic syndrome, what is that? Metabolic syndrome is a constellation of abnormalities that track with blood pressure, cholesterol, and diabetes. And it's very common. It's where you tend to keep extra weight if you get a little overweight and you carry it in your midsection. So your waistline bulges out, and then certain abnormalities in your blood test. So your good cholesterol is low, your bad cholesterol is high, you may be pre-diabetic or your blood sugar is a little bit off. And it's the constellation. In other words, you don't have diabetes all the way. You don't have high blood pressure all the way. You don't have high cholesterol all the way. But if you look at each one of those parameters, all of them are in the wrong direction slightly. And when you have that constellation, it all adds up to increase your risk. Kidney disease, if you have chronic kidney disease, not related to your heart, it's a kidney, totally different organ system. But people with chronic kidney disease have a higher chance of having heart events also. Chronic inflammatory conditions, so that's things like lupus, psoriasis, rheumatoid arthritis, anything where you have inflammation in your body in general raises the risk of heart disease because there's a big link between coronary disease and inflammation, which we don't have time to get into, but I could talk about that more. Premature menopause, so in women, the hormones seem to protect them from coronary disease. So while women are having their period, they're protected, their risk of coronary disease is much lower than men. After they go through menopause, they have this catch-up phase, and by about 2 years after menopause, women's risk is equal to men. And for some reason, doctors still think of women as not really getting heart disease, and so heart disease is always underdiagnosed in women. Because we look at a woman, we're like, oh, she's probably pretty healthy. But they really are equal after 2 years. And if a woman goes through early menopause, then that's more years that she's had without that protection. So that increases the risk. Certain ethnicities have higher risk. It doesn't apply to most of us here. There are the whole Ashkenazi Jewish things. That's not a thing so much for heart disease. It can be an issue for other genetic disorders, except for Ashkenazi food, which can be a risk factor, but we'll talk about that later. And then cholesterol and some of those other, the high sensitivity C-reactive, those are markers of inflammation. So those we've kind of covered. Okay, so let's move on. Okay, this is just to say that when we look at diet, there's innumerable studies, although a lot of these are not randomized, they're observational studies, that show that a vegetable-based, plant-based diet really seems to lower your risk. Now, there are not a lot of prospective randomized trials, so I want to don't go overboard with this, and it could be, well, maybe the people who eat like vegetarian-y type stuff just also exercise more and do other healthy stuff, and it's not really from the food. But the more data we get, the more we think there really is something to it, that shifting towards plant-based proteins is simply better than eating a lot of meat and the fat and cholesterol that comes with it. And there's one, this is just one interesting tidbit of a study they found. So this is the study where they looked at low carbohydrate diet. So in other words, this is stuff like South Beach diet, like Atkins diet, low carbs, right? I mean, that's all the rage now, right? So when you look at a low carb diet, and then they broke that up into 2 groups, okay? Where are you getting your protein from? If you do a low carb diet, you can get your protein from plants and beans and lentils and that kind of thing, or nuts. You can get your protein from meat. You can just have steak and fat and butter. Well, butter's not the protein, but you can get it from meat. The people that got all the protein from meat had an 18% higher, that's almost 1 in 5 higher mortality rate. And the people that got all their protein from plants had a lower mortality rate. Now, again, this is not randomized, controlled, prospective. People were already doing whatever they were doing, and people just watched what happened going forward. But it doesn't have the statistical power. It's a randomized trial. Still, it's very, very convincing when you see this repeated again and again and again. This is just an interesting statistic, and I think they say obesity, but I think it tracks with dietary trends in America. The deaths from heart disease had been going down since the 1950s every single year, primarily from better medical treatment, stents, the whole concept of ambulances and getting people to the hospital quickly for primary prevention, cardiac care units, the defibrillators to shock people out of rhythms, and all that. The mortality went down. We reached the nadir in 2015 where it started to go up again. And it seems that we have reached the limits, maybe this is one way to look at it, of what we can do kind of technologically. And we have to now use, more healthy lifestyle choices if we're going to reduce the rate further. So in that vein, exercise helps. And the good news is that any amount of exercise is better than none. So if you just don't do any exercise, if you just start like walking to the mailbox and back, you're going to get a large amount of benefit for that. And everything you do more, you'll get more benefit, but there's a trending, it diminishes the more you do. But just walking, and the good news is, like, you don't have to feel like it's really hard in order for it to be counted as exercise. Just moving, just walking, from people who don't, make a big, big difference. And this is hard, and people have hip problems and knee problems and all that, and it's hard. People have pain issues, but if it's, it's worth putting in the mental energy, talking to your doctors to get your body to a place where you're able to do some physical activity each day, even if it means taking a pain medicine and just doing it when you need to exercise versus not, because you don't want to take the medicine, and that's understandable. Talk about it with your doctor in private, but you can get a lot of benefit from that. Okay, you probably, a lot of you have heard about aspirin. There's kind of a controversy now. I get asked this a lot with my patients. It used to be for years, we always would recommend everybody take aspirin, whether you had anything wrong with you or not. Just take an aspirin once you get to be like 60 years old or 55, whatever. So now the data is a little more iffy, and the most recent trial didn't show any benefit. And like anything, we always weigh the risk and the benefits. So everybody knows, or we always knew, because aspirin is a mild, very mild, but still blood thinner, that anytime you thin the blood, you're going to have more bleeding. So we always knew that we had to, the benefit of aspirin had to outweigh whatever little risk of bleeding there was. And we assumed that it did for years and years and years, and the most recent study says it may not. So the problem with that is a lot of people just like stop their aspirin. What it really means is that if you're a person who's totally healthy and has nothing wrong with you, so no high blood pressure, no high cholesterol, no diabetes, never had a stent, never had anything wrong with you at all, then yes, you may not need to take aspirin. It's a discussion, though, that you should have with your doctor, because there may be other reasons why you should. Because it may be like, even if you just had a screening, say you had a screening x-ray or something for something else, and it turned out negative, but they noticed some calcifications in your aorta or something, so that says that you've got plaque buildup, even though you don't need to do anything with it, you need to just watch it, but that might be a reason why I, as a cardiologist, would want you to take aspirin, because now I know you've got some plaque in there. So the bottom line is, it can be a complicated decision. It's not something you should just throw away your aspirin, but it is not blanket everyone take it anymore. And this is just kind of how they broke it down for us as doctors. It might be considered, they say, they don't even say don't do it, they just say it might be considered for primary prevention who are at high risk. So if you have some of those high risk features, they're saying that we as doctors should still consider using the aspirin if your risk of bleeding is not that high. It's kind of, they've left it as kind of, when I say they, I mean the guideline committee who kind of gives us our recommendations. They left it as an open question, more or less. Okay, moving on to blood pressure, and again, lifestyle changes. We have great medicines for blood pressure. I can get most anybody's blood pressure under control, no matter how bad it is. I do that a lot. But obviously, it would be great if we could get blood pressure controlled without having to use medication, right? That'd be awesome. And it's better and more natural and more healthy. So there's lots of ways that we can do that not everybody might think about. This is a complicated slide. I'm not going to go through all of it, but it's very interesting because it shows with non-pharmacologic, that means non-drug-based methods, how much lowering of blood pressure you can expect on average. And it's a little bit surprising when you look at it. Most everybody knows, if you go down to the third one, it says dietary sodium. That's the one everybody knows, or at least a lot of people know, okay, low salt diet, and it's good for you and it lowers your blood pressure. It'll get you down by 5 to 6 points in this hypertension column, right? So I mean, that's good, you want that, but look at a healthy diet. You may have heard of the DASH diet, which incorporates low sodium, but other things, and again, tilting towards more fruits and vegetables and nuts, and less meat. You can get 11 points. You can double the effectiveness of just going low sodium, of eating a whole holistic approach to your diet. And these are additive, by the way. So there's, and weight loss, if you're overweight, you also get 5 points, the same as low sodium. Increased potassium, which is healthy, although you have to watch it for people with kidney disease. It can be dangerous to get too much potassium. Physical activity, this is what we were talking about before. Roughly 5 points for all the different kinds of exercises. Just starting an exercise program can lower your blood pressure. And the bottom one is alcohol. There's been some controversy in alcohol. It always goes up and down as to what the recommendations are. This slide is talking about if you drink way too much, which hopefully here nobody does, lowering your drinking will lower your blood pressure also, because over drinking can raise your blood pressure in addition to a host of other bad things. Okay, I think this may be the last one. The other one is, because I get a lot of people, and you may have heard about this, but getting a calcium score. So who should get a calcium score? A lot of primary doctors like to do that. And what it comes down to bottom line it, is if you are a person who is medium risk, you've never had anything happen to you, and you're not high risk, and the question is going to come down to, again, do I need to take medication because I've done everything I can, my cholesterol's still a little high, should I take a statin? Because there's some issues in the community with statins, and are they good, are they bad? I can tell you blanketly they're good, and we can talk about that if you don't have side effects to them. But do I need to take that? And the calcium score can help you decide that. Basically, what it's telling you is there any plaque in my arteries? It's not telling you that exactly. It's a little more complicated because it doesn't detect what we call soft plaque. It only detects plaque if there's calcium already in it, which is a late finding. Nonetheless, if you have calcium in your arteries, that should not be there. That means you have plaque there for sure. And then you can move on and investigate that further, but you definitely need to probably be on a cholesterol medicine if that happens, and sometimes that can that can tip the balance. Yeah, so that's the end of my slide. So I know I went through that fast, but I wanted to keep it open for questions. So if that piqued any interest, or if anyone has even unrelated questions, that's fine. I'm here.
First of all, thank you very much. Pinky is going to walk around with a mic for anyone who does have a question. For those of you on Zoom, we'll be following. There's a speaker right at the podium here. He'll be able to hear your questions, but we're going to try to catch them in order so people don't interject. Go for it.
I have a question about drinking water. Does that lower or raise your blood pressure, or any other benefits that you want to mention about water?
Yeah, that's a good question. So water's good. You should drink it. Bottom line. I don't have data on blood pressure reduction like I do for that, but I can tell you, drinking a lot of water throughout the day is way more important than a lot of people think, for a variety of reasons. Number one, our sense of thirst, and this they've studied scientifically, actually gets dulled the older we get. So if you're, like over 65, and you wait till you're thirsty to drink, you are dehydrated all the time, guaranteed. And that's bad for your kidneys. That causes an adrenaline response, because dehydration is going to tend to lower your blood pressure. Your body senses that. Your body revs up your adrenaline levels to try and counteract that. And that's going to raise your blood pressure and your heart rate. And that does bad things over time. In addition to, it can make people dizzy and pass out and all that. And it can help with your diet, because by drinking water, you keep your stomach full. You tend to feel more full and less hungry. So I can't speak highly enough about that.
I assume when you said not use aspirin, you meant for prevention, not for regular use of a cure for disease, for maintenance. Okay, number two, is there any way you could talk a little bit about bypass surgery, valve replacement, pacemaker, everything?
So first of all, I want to be very clear on the aspirin. Yeah, that's exactly correct. I was talking, so if you take aspirin because you had a heart attack, or you had bypass, or you have a stent, keep taking your aspirin. 100%. In fact, if any of you take aspirin for any reason, do not stop it because of anything I said today. Talk with your doctor about it, or you can ask me in private later. But yes, if you're a person who does not take aspirin and you're totally healthy, which is, I mean, it is a lot of people, but you really have to go through everything and make sure there's like no high risk features, then yes, you might not need to start taking it, whereas we used to say, take it anyway. As far as talking about all the other stuff, I'm happy to do that. You mentioned a lot of things, valves and bypass and all that. If there's one in particular or you know, that you have a question about, I'm happy to go through just what they are in general or what the new technology is.
Here's a quick Zoom.
Okay, a Zoom question.
So you can read out loud.
Which one is this? Okay. Okay, this is from Zoom, so I'll read it. They say President Biden has atrial fibrillation, but is only on a blood thinner. No anti-flutter med like Ticacin. Okay. Should he be on such a med? Okay, that's a good question. That's a very high level, complicated question, but okay. So hold on, I'll answer that and then we'll come here. So if you have atrial fibrillation, the brief thing on atrial fibrillation is that there are two problems with atrial fibrillation. Atrial fibrillation, for those who don't know, is in layman's terms, it's an irregular heartbeat. So normally our pulse beats a regular rhythm, it keeps beat like a drum, and in AFib, it's like fast and slow, it like loses all its rhythm, it's just random. And there's other stuff with it, but that's the main thing. And there's a risk of having a blood clot, there's a risk of having a blood clot with AFib that if the piece of that blood clot breaks off and goes to the brain, can cause a stroke. So the one big thing we worry about in AFib is that we don't want anyone to have a blood clot or a stroke, and that's why we use blood thinners. The second part of AFib is that when the heart's beating irregular, essentially what that means is our own natural pacemaker. This is not a pacemaker that you get put in like a metal box. This is our own natural pacemaker that we're all born with. It's as if that goes offline, and that's why the heart's irregular. What that means is the heart can go way too fast or way too slow. The tendency in most people is for the heart to go way too fast. And therefore we use medications to slow it down. Sometimes there are some medicines like Ticacin that the questioner mentioned that we can use to actually try and keep the heart out of AFib and back in regular rhythm. And there's a series of different medicines we can use to do that. Ticacin is one, sotalol, amiodarone, there's other medicines. If we can keep the heart successfully in regular rhythm, then we theoretically don't have to worry about the problems of AFib. And so, yeah, we try and do that sometimes. And sometimes we just use medicines to prevent the heart from getting way too fast or way too slow. And sometimes if the heart's kind of going in a good rate and it's not going too fast or too slow anyway, then all we worry about is the blood thinning. And so it turns out that it's very individualized, and it depends on a variety of other factors, and it also depends on how the AFib is bothering you. Some people have a lot of symptoms with it, others don't, and we take that into account into the types of things we do and the treatments we offer, because each medicine we use has side effects. Okay, so there was a question here. Let's go here and then here.
One of your slides mentioned processed foods. Now, I venture to say that many of us eat deli, which is highly processed.
Yeah.
Okay. I know that's not good, but it seems that creeps into our diet periodically anyway.
Yeah.
Maybe you can elaborate on that. That's number one. Number two, I'm on 5 milligrams of Crestor every day.
Sure.
What is that telling me?
Okay. So the deli meat, yeah, I love deli meat. Okay, my wife makes turkey sandwiches for the kids for school. We shouldn't eat it. I mean, we should eat it sparingly. It's got a lot of sodium and it's got a lot of nitrates, and if you're going to eat meat lean, like a lean piece of steak is kosher steak is better, rarely, than deli. Nonetheless, you know, you got to live a little, and if deli is easy to get and cheap and whatever, and it makes a good sandwich, but sparingly. With regard to the 5 milligrams of Crestor, so Crestor is a statin. It's a 3rd-generation statin. It's very good. It's rosuvastatin generically. Crestor and Lipitor are the 2 3rd-generation ones that are very strong. They'll lower your numbers a lot. I like them. They work very well. They really protect people. what I find in my practice is most people are on too small of a dose. The farther we go along in medicine and the more we learn that lower is better. We used to get people, just to give you some numbers, their LDL, which is your bad cholesterol, we used to want to get it below 100, then we lowered it, like for diabetics, below 70, then we lowered it for like, well, everybody should be below 70. Now we're seeing that we're ending up getting it down to like the 40s. And we're doing that simply by using higher levels of these medicines. The medicines can have side effects, but usually they either do or they don't. There's not a cumulative effect. It's not like if you take a higher dose, it's going to slowly build up in your system more and more. They don't work like that. It's almost like an allergy. If you feel bad with it, you shouldn't take it. It's never something you should be like, I'll put up with it, I can take it because I want to do what's right. If you have a side effect, you should get off it, 100%. But we probably should be using higher doses in those that can tolerate it to get the numbers way, way low. And the last thing I'll say, and then we'll get to your question, I know I'm talking a lot, but this is important, is that when we don't know, when we do everything we do in medicine, right, we don't actually have the instruction book, right? Like when the big man upstairs made us, like he didn't give us the instruction book, so we're like making it up. So when we look at what are the normal cholesterol levels that we should live in, right? How did we get that? We took 1 million or several thousand random Americans who we thought were healthy in the 1950s and measured their cholesterols. Well, I don't know, they were eating like American food in the 50s. Is that normal? I don't know. So now when you look at what is the closest you can get to where we were evolved to live at, right? So you can do that in two ways. You can get blood from primates, our closest relatives who live in the wild and eat nuts and berries and whatever, and you can get that from human cord blood, right? So what that means is the umbilical cord of a newborn right when it's born, before it's eaten anything. And you look at LDLs in those two populations, you get LDLs in the 40s. So living at an LDL of 100, which your primary doctor will tell you is great, is probably more than double what we should be living at. And that's part of the reason why we've lowered. In addition, the studies show it works better. Okay.
Going back to AFib.
AFib, yeah.
We talked about numbers.
Yeah.
Today, at one point, you're saying 75 and you drop down to 58.
Yeah, you're talking about heart rate in AFib because it can go all around, yeah. So where your heart rate ends up, there can be a wide range, and a lot of that depends on kind of personally how your body handles it. So we let people run in AFib with heart rates up in the 90s, and it could be down as low as the 60s or so. And if there's some bouncing up and down temporarily, we don't care so much, so long as you're feeling okay. We wouldn't use medicine to purposely get someone's rate all the way down to like the 60s. That would be too low. And the reason, it's not that 60 is too low, it's just that if on average it's that, we know it's going up and down, and we don't want the lows to be too low. So we have to we know that there's always peaks and troughs, so we need to keep the average in range. Yeah, natural. So there are natural things we can do. I'll take, because it's 1 o'clock. We'll do one more question after you.
I want to make sure.
Okay, yeah, just one more question, then I got to go because my office. They haven't called me yet, but they're going to. Natural things are great if we can, and there are natural things you can do to lower your heart rate. Number one, just by staying healthy with other stuff, by drinking enough water, because your heart rate will go up if you're dehydrated, by doing things like yoga, meditation, eating a healthy diet. All those things will lower your heart rate, and we do that. It's just hard for a lot of people, so we use medicines kind of in the meantime to provide some protection. Vitamins, yeah. D3, yeah, vitamin D is good. You should check your levels though, because there's a lot of data that shows that taking a bunch of excess vitamins just because we think they could be healthy don't help really, but they should be targeted to where you need them. There was one question in the back, and then I'm going to have to run.
I see advertised on TV a machine or something to give an EKG. Yeah. Is that reliable, or is it meant just to scare us?
Right, it's a good question. So there actually are a lot of kind of consumer-oriented devices now which can check telemetry strips like an EKG, like a single lead EKG. And they range from like just an Apple Watch to other devices that go on your phone that you hold with 2 fingers to get a strip. And there are several of these. There's probably going to be more coming down the pike. To be honest with you, in general, the ones I've seen are pretty good. And they don't always, but they do result in a fairly reasonable, if you hold it right, tracing. The alerts they give you, they often, and they do this on purpose because they don't want to miss stuff, are oversensitive. And a lot of the ones I've seen, they'll tell you something's wrong when there isn't something wrong, really. Nonetheless, they can be useful for people to become more in touch with their body. Usually their heart rate numbers are good, but the problem is that also has problems because if you have like 1 extra beat, so it comes close to the beat before it, and the algorithm in the computer in your little device measures the distance between the 2 beats to derive a heart rate, and it'll tell you your heart rate spiked up to 200 or something crazy when all it was 1 extra beat. But you on your Apple Watch, I get patients coming to me all the time saying, yeah, my numbers, like it will go up to 200. It's not really that you were up at such a high rate. You just had 1 extra beat, and the computer misread that as a high rate. It lasted less than a second. So they need to tweak the algorithms a little bit, but the tracings we get are good such that if you have a situation at home where you feel dizzy or whatever, something's going on, and you get a good tracing out of it, sometimes that actually can be helpful to us medically. And I've had patients bring in tracings and we go through them together, so that's good. All right, I gotta run, unfortunately, to see patients. Yeah.
I just want to say thank you again. For those of you who wanted Dr. Brodsky's contact, I left that up on the screen. The clinic number is up on top. Thank you so much. I had the water there.
Okay, no.
Take 2. But again, thank you again. Of course, on our end here, you're welcome to stay and schmooze a bit, or hopefully we'll see you at one of our next events. So again, thank you all for joining. We really appreciate it. And if there are any questions for us, we're here always for you. If you know that there's something that we can add to our programming, we always appreciate ideas. So thank you.